So in this video we're going to be discussing management of feline epilepsy. And the first step is to establish, are you actually dealing with an epilepsy? Is it genuinely a seizure? The amount of drool that's coming from this mouth of this cat is a big clue that the cat has or is having a seizure, but obtaining a video would be most useful. And there are a number of things to rule out. For example, with this little cat here, we can see this kind of jerking action going backwards with the head, with the eyelids closing, is characteristic of myoclonus. Now, these can be myoclonic seizures or associated with seizures, but cats with this type of problem may do better with Levetiracetam therapy than with Phenobarbital therapy, and we'll discuss that later. As you can see, this backward sort of head nodding type action. This is a spontaneous myoclonus. There was no obvious trigger, but you can see an audiogenic myoclonic seizures in especially the Burman cat, although as many cases have been recorded in domestic short hairs. And if you just look at this video here, you'll see these little jerks in this cat when I crinkle a bag. And these are also myoclonic jerks, not quite the same as we were seeing in the other cat. And with enough sustained noise, they can train through to give this Burman seizures. And this cat was also on management for generalized tonic-clonic seizures. Seizures in cats can be really violent and very distressing, as we can see in this poor cat here. Again, the video is very useful to confirm that that's exactly what it is, as we're going to compare to a very similar syndrome in the next video. You can see how the cats with even generalized seizures can really propel themselves around the room. Imagine if they're also urinating and defecating, that can be very messy. We can see in this cat here the profuse salivation and the mouth action, which helps confirm that it is a seizure with these orofacial autonisms. In this cat, it also has some tonic extension and flexion of one side of its body on the right side of the body, and this may be temporal lobe seizures in this cat, or at least coming from a temporal lobe focus, because typical temporal lobe seizures in cats will have oral facial automisms down one side and extension of the limbs on the opposite side. Seizures need to be distinguished from movement disorders, which are less common in the cat than they are in the dog. And this is a suspected paroxysmal dyskinesia in a domestic short hair. You can see this kind of flexion, usually of alternate limbs, starting often with a forelimb. This is a segment of longer video in this cat. This episode went on for a very long time. We can see these kind of movements of the left pelvic limb, and the cat is having difficulty walking. However, this cat is walking with a purpose, unlike the seizuring cat that we saw in the last video. And you can see it's going for its little box here, looking for the reassurance of being in a more secure space. So the fact that the cat is making a cognitive decision to move towards the box helps to distinguish that this is a movement disorder, a suspected paroxysmal dyskinesia, as opposed to the seizure that we saw in the last video, even though you could argue that that cat was also moving its limbs. I'm not going to talk much about the diagnostic workup because this video is going to focus on treatment, but just to say that these are the causes of seizures. It looks like a very busy diagram here, and indeed it is, but I like to divide it for my owners into things going wrong with the brain and things going wrong with the blood. In the blood, we can have toxins that are coming from internally, such as hepatic encephalopathy or renal failure, or externally. Permethrin, before it was withdrawn in this country, was a common one, and recreational drugs maybe can also be seen less commonly in cats than dogs. We can also have too much or too little of each of something, such as electrolytes or glucose, and these should be ruled out by your hematology and serum biochemistry, and if appropriate, urine toxicology on the toxins. We can also see some inherited metabolic diseases, for example, CAD deficiency in Bengal cats. Then we deal with the intracranial causes, and idiopathic epilepsy, where you have no structural abnormalities, is definitely recognized in cats, but is not quite the same as in dogs, because dogs have an inherent susceptibility to inherited epilepsy or breed-associated epilepsy, because genes for epilepsy susceptibility are associated with genes for successful domestication. There has been a suggestion of breed-related or variety-related in the British shorthair cat, but that has been unproven. So basically you're just as likely to see idiopathic epilepsy in a domestic shorthair as you are in a more inbred, purebred cat. Structural epilepsy is probably the most common type of epilepsy that we see in the cat, but it doesn't necessarily mean that it's associated with progressive brain disease like hypertension, the infectious diseases like FIP and toxoplasma, brain tumours. And I would also include the inherited audiogenic epilepsy in the Burman cat, or at least it's suspected to be inherited, because it does seem to have a progressive component to it, and of course autoimmune limbic encephalitis. The progressive brain disease are obviously a very important cause, but we can also see a non-progressive brain injury, secondary to trauma, or the consequence of autoimmune encephalitis, which can have permanently damaged the brain and leave the cat epileptic. How do we distinguish between these? Well, the most important is the neurological examination in the interictal period, and if it's affordable to the caregiver and appropriate, then perhaps MRI, CSF analysis and other specific tests. Remember, when you're ruling these things out, that you can have a transient hyperammonemia, i.e. high ammonia level following epileptic seizures in cats. So be cautious if you see that, not to make an assumption that it's a hepatic encephalopathy. And remember that there is research into limbic encephalitis or temporal lobe epilepsy in cats, and it's definitely worth finding where you can do diagnostic testing for your country. This is the form that we use in Britain and also in Vienna, which is covering more continental Europe. I'm not so sure that there is testing available in the States, but I'm sure that Dr. Sophie Binks, who is a wonderful lady researching this disease in cats at Oxford University as part of the Oxford Autoimmune Neurology Group, would be welcoming samples from all over the world. I'm not going to talk about limbic encephalitis, temporal lobe epilepsy in this lecture. Apart from here, I have a whole dedicated lecture on that, which is Brain on Fire, Mudis's story, and I'd refer you to that. With neurological examination, the aim is whether or not there's neurological deficits. And if it's normal, I suggest repeating and repeating. Your neurological examination is going to give you the biggest clue as to whether or not there's structural brain disease. And if you find there is forebrain disease, you need to remember the 4x4 brain signs, which we're going to go over in the next slide. And of course, cats are predisposed to having infectious diseases, which will have a more multifocal process, and some tumours are multifocal as well. So if you're seeing seizures and vestibular disease, think infectious, inflammatory, and multifocal tumours. This is an example of a neuro exam sheet, and you can download those from my website, QR code there, and the web address there. So what are the 4x4 signs? So this is circling towards the side of the problem. And then we have central blindness, which is the opposite side to the problem because of decuppation. So they'll have blindness, but a normal PLR. Proprioceptive deficits or paresis, which is the opposite side of the problem, so the opposite side to the circling, and obtuntation and behaviour changes. So that's my handy hit, the 4 brain signs with forebrain disease. When should you do MRI or CSF analysis? After exclusion of reactive seizures, and of course some caregivers will want to proceed with that anyway because they have the finances available for it or they're insured for that sort of thing. But otherwise the indications are interictal neurological abnormalities, so consistent with an intracranial neurolocalization, status epilepticus or cluster seizures at the epileptic seizure onset. In a cat though, I'd have to be very suspicious of limbic encephalitis. I do have a 3 tiers of diagnosis confidence for that disease. So again, I refer you to that lecture. And then when you're really struggling to treat them, so if you're giving multiple drugs and you've dosing appropriately and you're not getting anywhere, then maybe the next step is to do an MRI scan to look at possible causes. So now we're going to concentrate on setting up treatment. And of course, cats have their own unique problems. And the most important one is that owners often find giving pills to cats very challenging indeed. And this can be a significant source of distress to caregivers and of course to the cats. The other thing bearing in mind is that cats owners are different from dog owners. Dog owners have structured their life around caring for a dog, which means not leaving the dog for long periods of time. And so it is much easier for a dog owner, generally, this is a generalization, to give a medication every 12 hours and perhaps every 8 hours. People who own cats are perhaps chosen a cat because of their greater independence, and they may be working longer hours and may struggle to give that regular medication, and especially may struggle to give 3 times a day medication. And so it can be just bear in mind as the veterinary surgeon for an owner of an epileptic cat that it can be very challenging for them just to comply with giving medication. When do I start giving treatment? This again is a generalization, but if the seizure frequency is less than 12 weeks, if there's clusters of seizures, if there's status epilepticus, if the duration of the seizure is for more than 5 minutes rather, or if the frequency of the seizures is generally increasing, or if there is a high risk of recurrent seizures. So this CT and MRI scan is from a cat that had presumably suffered some brain trauma. So this bit of bone here is meant to go continuously across here, but this little bone is pushed in, and this is the brain actually herniating out of the skull and into the frontal sinus. This is the frontal encephalocele, and this is the brain coming through here on the MRI scan, and this white stuff here is actually the CSF. And this cat was rescued by a receptionist for a local veterinary practice to me, and the cat very quickly was observed to be having seizures, and always this cat had a nasal drip, which was the CSF coming through. So this cat will always have a susceptibility to having seizures, and if you know that, then there's no point in waiting to start them on the therapy. So what therapy do we use in cats? Again, our decision making for cats, I think, often has to be based around what is the easiest medication to give. And so for me, that actually is phenobarbital, although that does have some adverse effects in cats. And the reason why I'll go for phenobarbital first is I'm looking for a drug which is the most likely to stop the seizures and can be given the least frequently. And it doesn't work in all cats, but in many cats you can get away with giving phenobarbital once daily, and I generally give it in the evening so that the impact of the medication is overnight when the cat may be sleeping. But of course that depends on the cat. Some cats do like to be out a lot during the night, but on the whole most cats are crepuscular, so they're more active in the early morning and in the late evening. So that's why phenobarbital would be my choice there. I generally give the phenobarbital tablets. There is a liquid phenobarbital formulation that is available, but my experience is cats absolutely hate it because it is flavoured with orange, and owners will really struggle to give that, and the cat certainly won't accept it in food. Bear in mind, phenobarbital or any other anti-epilepsy agent is not licensed for cats. There is no licensed anti-epilepsy agent for cats, and therefore you need to advise your clients appropriately. And in the UK, that would also include having them sign the appropriate forms to have them understand that. And of course, to understand that, they need to know all of the risks. You should be monitoring the serum concentration, and that can also be a problem for cats because then they have to go into the vets and have a blood sample taken, which can also be stressful for them. In cats, I'm aiming for slightly lower than in dogs, and so in cats, I'm aiming for 20 to 25 mg per litre, which is 100 to 125 micromoles per litre. In the dogs, I'm aiming for that 25 and 125. However, you might find some cats are stable on a much lower dose than that, and if that's the case, then I wouldn't necessarily increase if they were seizure free. So what are the adverse effects that we see in cats? Well, the common ones are sedation and drowsiness. And that can be a big issue for cats because, of course, cats jump, and owners will notice that their jumping ability can be substantially off when they're on phenobarbital. Reduction in activity, increased appetite and weight gain, of course, increased urination and drinking. We can also see some quite serious adverse effects in the cat. They are rare, but they are definitely something that you need to know about because it perhaps might surprise you. So facial pruritus and cutaneous eruptions. The most important, however, is pseudolymphoma or phenobarbital-induced anticonvulsant hypersensitivity syndrome. So cats with this will appear very ill indeed, and you might suspect that they even have a cancer called lymphoma, so they can present with tachypnea, pyrexia, high serum amyloid, reactive lymphadenopathy, really big lymph nodes, pleural effusion, a splenic reticular pap, and even a coagulopathy and hemorrhage. So if you have a cat on phenobarbital and you are seeing unusual signs, then it's probably something else, but think adverse reaction. We can also see hematological problems such as pancytopenia, so that means a destruction of all of blood cell lines, or neutropenia, or even systemic lupus erythematosus. It's metabolized by the liver, so there's a potential hepatotoxicity, which people are often worried about. And this paper kind of looked at that. So what is the issue with phenobarbital in the liver? Well, generally with all drugs, especially with cats, the more rings they have, then the more necessary it is for them to have liver metabolism. And that's particularly important in the cat because they, as obligate carnivores, they have a more simple liver metabolism because they don't have to deal with toxins like dogs, which are more scavengers, are more capable of dealing with. So on the whole, dogs are very good at getting rid of toxins, including drugs, and cats aren't not. So drugs like gabapentin and levetiracetam do not require liver metabolism, whereas drugs such as phenobarbital, zonisamide and CBD oil do require liver metabolism and can induce and can result in increases in liver enzymes. And this is why I don't recommend CBD oil for management of epilepsy in cats, because you really will have to monitor the liver function and liver enzymes in any cat receiving that drug to any dose that will actually affect seizures. So how do we avoid hepatotoxicity in the cat? Then avoid combinations of drugs that are metabolized by the liver. Monitor the serum concentrations and maintain with our therapeutic serum concentration. Avoid dosing phenobarbital high or more than the serum concentration that I've indicated there. Do liver enzyme and function tests, and bear in mind that unlike the dog, in the cat, phenobarbital does not result in liver enzyme induction. So in dogs, we're pretty used to seeing an increase in ALT and ALP when a dog is given a phenobarbital, but in cat, if there is an increase, then you should consider that significant. What are the other options? Well, actually, it's something I've never used in a cat, but Imepitoin is an option. There was a very small study, which I've indicated there, where they found 50% of the cats achieved seizure freedom for at least 8 weeks under treatment. They had lethargy, decreased appetite and vomiting, which was described as mild and transient in some of the cats. Pexion, of course, has an anxiolytic effect, which might be useful. One of the things about Pexion, which could possibly make it attractive in the cat, is that you don't have to measure the serum concentration. So if coming into the vets and having blood samples taken is a really big deal, if it's just not going to work for that particular caregiver, then maybe this is the drug of choice for you. Then we have Levetiracetam, or Levetiracetam, depending on how you want to pronounce it. And I've put the trade name in there, Keppra, because that's one a lot of caregivers say because, frankly, they can say it, and Levetiracetam is a little bit of a mouthful. So Levetiracetam is a small molecule which has both anti-epileptogenic and neuroprotective effects, and it has a completely different mode of action compared to phenobarbital, and it's safe for the liver and is eliminated by the kidney. Now, the problem with Levetiracetam is that it has to be given 8 hours, even in a cat, although to be honest, because it probably has a longer half-life in the cat than it does in the dog, I will initially try it at every 12 hours and see what happens. When do you use it? Well, it is the primary therapy for audiogenic reflex seizures and other myoclonic epilepsies. And so I'll definitely kind of use it in that, especially as it has a low side effect profile. And it can be used as an add-on for refractory epilepsy. And there are higher dose protocols for cluster seizures and status epilepticus, which I'm not going to go into here. So if you live in the States, then it may be an option for you to use the extended release formulation. There has been a paper that described using that per cat per day, 1 tablet per cat per day, which will certainly get over the problem of having to give it 8 hours. That's not something that I have experience with because it's not available in Europe. The other option is that I have tried using the liquid formulation. Caregivers can have variable success giving liquid. Sometimes trying to sort of squirt liquid in a cat's mouth can be as unsuccessful as trying to put down a tablet. However, sometimes people can successfully mix that with food. So what happens then if the seizures are not controlled? And this paper here I found very interesting, looking at the impact of epilepsy in the cat, and it's no surprise really that quality of life was graded as significantly higher in cats with controlled seizures, no adverse effects from medication, and for owners that felt supported by their veterinary surgeon. So first of all, you need to establish if there's enough drug. Bear in mind, cats are very, very good at spitting out tablets or removing them from eating the food from around them. Bear in mind that some laboratories may give you a misleading laboratory therapeutic range. Stick to the ones that I've given you. Some of them have very wide ranges that are based on quite old data. Is the owner dosing correctly? Are they giving every 12 hours rather than twice daily? Sometimes our default computer sticker prints out a label that says twice daily, which isn't very helpful actually. I always have to manually change hours to every 12 hours if that's the case, or every 8 hours. And sometimes there can be a very simple misconception. Well, I feed my animal twice daily, it's much more easy to give the medication in food, and I feed my cat at 8 a.m. and 4 p.m. and then you just pop the tablet in there. But of course that's not every 12 hours. So what do you need to do? Well, you can go high within the therapeutic range. You can increase Pexium right up to the maximum dose without measuring the serum concentration, but often that is limited by the adverse effects. I have to say that I don't have an image of this myself, but so I'm going to gratefully thank Belmead Animal Hospital for this image that I found on the internet and acknowledge them here. This is transdermal phenobarbital. Not something that I've ever used, but transdermal applications are certainly tried in many cats because it's easier to give. And this dose here, 9 milligrams per kilogram, so this is about at least 3 times the dose that you would give orally, to start with anyway. Every 12 hours achieved a therapeutic serum concentration. But look at the range here. This is quite a broad range, and so and imagine for those cats that the actual serum concentration might vary from day to day as well. So it might be an option for that very, very challenging animal if you can get the agents being compounded. So, what other options do we have for the challenging epileptic cat? And this is one of my cases that was particularly challenging. He taught me a great deal. This cat, you can see a lot of white on this MRI scan. This is because the brain is atrophied, and this is secondary to having toxoplasmosis. So this cat was successfully treated for toxoplasmosis, but unfortunately the amount of brain damage that was done left him with refractory epilepsy. So this is what I do when managing epilepsy in the cat. I'll start phenobarbital, as I've said before, because often I can get away with it once daily or twice daily, and as a small tablet, owners generally find it one of the easiest to give, and it's effective in many instances. If that has unacceptable seizure control, then I will add Topiramate. Why Topiramate? I don't use it in dogs because it's got a short half-life, or I don't use it very commonly in dogs for epilepsy. But it's given twice daily and it is fairly liver safe. If that is still unacceptable, then I'll add Levetiracetam, but for many cats that's going to have to be 3 times daily. By this stage, they're on 3 different drugs, so I'll definitely consider reducing or withdrawing other drugs. And then if that's unacceptable, I'll add Zonisamide, and then almost certainly I'll have to reduce or withdraw the Phenobarbital or Topiramate. Now, this may vary from country to country. In the UK, then our Cascade guidelines, laws, state that when we're managing cats' diseases, we should first choose a drug which is licensed for another veterinary species, particularly the dog. So that is why I would choose phenobarbital first. In some countries like the USA, they may actually just go to Zonisamide first, because they don't have the same guidelines. Zonisamide is not necessarily more effective than phenobarbital. If the seizure control is acceptable, or there is a drug-induced absence of seizures, then I will review the serum concentrations, bloods, etc. So what is Topiramate? Complicated drug that has a number of different actions, as we can see here. I have a dedicated YouTube video just on it. It's an anti-epilepsy drug, and it's a first-line migraine medication in humans, and it also has a number of other properties. It can lower intracranial pressure, at least in rodent models. It can be used for some peripheral neuropathic pain conditions in cats, and in humans it's also sometimes been used for obsessive compulsive disorder, but in this instance we're using it obviously as an anti-epilepsy drug. It's a lower dose that I use in the cat compared to the dog. whereas the dog, because it has a short half-life, you generally have to give it 10 milligrams per kilogram every 8 hours. You need to monitor blood work with this drug. Hematology, serum biochemistry, including electrolytes, and I monitor the blood serum concentration, aiming for within the human range. Some cats will not tolerate Topiramate. They'll become quite sick indeed. They can become too sedated as well. So usually gastrointestinal intolerance, nausea, diarrhea, can become anemic, but most importantly it can induce a metabolic acidosis by causing a renal tubular acidosis. It's been described in the literature that they're hyperkalemic. My tip for this is that the chloride goes up first. And that is one thing that I'm really looking for, especially if the cat is unwell. Zonisamide or Zonigram is dosed at 10 milligrams per kilogram twice daily. Again, I'm aiming for a serum concentration within the human range. There's evidence that it's useful as a monotherapy, and this was a nice study that was looking at a familial spontaneous epileptic cats in Japan, and it also has very similar adverse effects to Phenobarbital and can also cause an anticonvulsant hypersensitivity syndrome. So what's the prognosis for feline epilepsy? Actually, it's pretty good, probably better than many dogs, because 50% of cats treated with Phenobarbital alone or combination with other anti-epilepsy drugs will actually become seizure-free, which is not the same as in dogs, because most dogs with idiopathic epilepsy will continue to have occasional seizures. And then of the others, many of them were considered to have good or to moderately well-controlled seizures, so 1 to 5 seizures a year, and also described to have shorter seizures and less severe seizures. However, like dogs, like humans, up to a third are poorly controlled. One thing that's quite important in cats is that when you become seizure-free, of course, many owners will naturally want to stop the therapy, and will be seeking your advice on that. However, this study found that cessation of treatment may lead to recurrence of seizures in most cats, even if free of seizures for years. And my experience with that is that once they have had a recurrence of seizures when you've taken them off medication, it is not a simple case of just popping them back on those drugs that controlled them again. They can be extremely challenging to control. And so withdraw that therapy with caution, and to be honest, if the owner is managing to give medication, I wouldn't advise that. The other thing to bear in mind is there are surgical options, and leading the field in this is my colleague Professor Hasegawa in Japan, and he has published a number of case reports where he's been doing surgery on cats in particular with epilepsy, and if you're interested in that, I compel you to read his excellent articles. So that is where we're ending our deep dive into management of feline epilepsy. I hope you found it useful, and I'd like to thank all the caregivers who gave permission for their videos to be used for teaching purposes, and thank you for listening. Bye bye.